Sir, we are live now.
Okay.
Sir, we are live. We can start the session.
Yeah.
Hello. Sir, we can start the session now.
Oh, yes. So you want me to begin?
Yes, sir. Yes.
Okay, sure. I will. So good afternoon, everybody. I'm Dr. Rajesh Jindal from Medulla Cancer Cure Center. I'm the medical oncologist over here and the medical director as well. This session will be on hepatocellular carcinoma, and I would start with a little bit of epidemiology, a little bit of etiology, clinical signs and symptoms, which I'm sure you are all aware of. But then it will help if we can go through it and to refresh our memories once again. A large part of the lecture, of course, would be about the treatment part of hepatocellular CA. So considering this, okay, now HCC in India. Well, I would be more concerned, just like all of us, about India only. So I will not be quoting figures from the WHO or from the US. So these are Indian figures from the provided by the ICMR. And the incidence per 100,000 males varies from 0.7 to 7.5 people. Women are more lucky in the sense that their incidence is about 1/4 of that of men, and hence the male-female ratio is about 4:1. In the mortality also, women are more lucky. They just have about 5.1 deaths per 100,000, whereas males have 6.8 deaths per 100,000. The age bracket, however, remains the same, which is between 40 to 70 years of age. Cirrhosis, of course, carries a high mortality at 1.6% per year if we compare it to this thing. So then comes the risk factors. We all know and we're all aware that hepatitis B is a major risk factor for having hepatocellular CA, which is why it tops the chart over here as well. This is followed by hepatitis C virus. Then comes chronic alcoholism. Chronic alcoholism, due to its varied other associated factors, also leads to an increased risk of having hepatocellular CA. Then comes non-alcoholic fatty liver disease, followed by non-alcoholic steatohepatitis. They may not be necessarily in this risk order, but then they've all been enumerated here. Then comes genetic hemochromatosis, HIV plus minus HPV infection or HCV infection, or it could be alpha-1 antitrypsin deficiency, and lastly, stage 4 primary biliary cirrhosis. They would all be risk factors for contracting hepatocellular carcinoma. Now, when we see that hepatocellular carcinoma, as of like when we are trying to screen for all of the malignancies, for breast, for lung, for head and neck, for stomach, and for GI cancers, we might as well screen for hepatocellular CA also, and it is done for all the people who are at risk, regardless of their age. So we've seen the risk factors earlier in the previous slides. Now, ultrasound is for patients who are at risk, of course. Ultrasound is a nice modality to see and evaluate the liver. It is fast, it is quick, it is cheap, and it is easily available in India. Alpha fetoprotein is a blood test, of course, and it can be, now the alpha fetoprotein is kind of debatable in the sense that we've not been able to establish an exact cutoff point that after this point, you can be sure that it is hepatocellular CA. Various studies, various experts have used various cutoffs, which can be seen over here. 20, 100, 200, even 400 has been used as a cutoff for diagnosing hepatocellular CA. But more important than the absolute value is a rise of about 7 nanogram per ml per month, they say, is more useful. The best screening procedure, they say, is by a combination of ultrasound as well as alpha fetoprotein. And for the population, for the people who are at risk, who have those risk factors which we saw in the last slide, the screening should be repeated every 6 months, which might be kind of expensive for certain groups of people, but then that is the recommendation. And if we detect a liver nodule more than a centimeter in size, which is 10 millimeters, then we might employ a CT scan or an MRI also to detect or to confirm whether we've got a hepatocellular CA on our hands. Quick run through the signs and symptoms. Most of the patients which you and I see are generally asymptomatic. They come with very little problems. They come to you with something else, and upon a routine ultrasound of the abdomen, we find that he's got an SOL, which on subsequent evaluation turns out to be a hepatocellular carcinoma. The signs and symptomatology could range from jaundice, anorexia, weight loss, malaise, upper abdominal pain, hematemesis, hepatomegaly, ascites, hypercalcemia, hypoglycemia. All of these symptoms may suggest that the patient may have an underlying hepatocellular carcinoma. The imaging modalities that we employ to evaluate or to assess hepatocellular CA will be a contrast enhanced CT scan and utilizing the multi-phasic liver protocol, MRI, contrast enhanced ultrasound. This may be useful for indeterminate nodules which are 8 millimeters, 12 millimeters, do not show anything else out there upon a normal ultrasound. We can do a contrast enhanced ultrasound on these people and see whether these nodules, which way do they go? They go towards HCC, they go towards the cirrhotic nodule, or they go towards anything else. A PET CT is done, but it is done mainly to assess the prognosis of the person rather than establishing the diagnosis. Alpha-fetoprotein, we all, as a matter of reflex, also write alpha-fetoprotein if we are suspecting a liver cancer or if we are suspecting an abnormality of the liver. Alpha-fetoprotein, however, like other tumor markers, is an inaccurate marker. It can raise the level of suspicion, but it may not be diagnostic. However, levels exceeding 400 nanograms per ml, which are seen in only a small number of patients, they are usually accepted by experts as diagnostic of alpha-fetoprotein. But then, having said that, about half of the patients, which is 46%, to be more precise, have a normal AFP value which is less than 20. Because alpha-fetoprotein may be raised because of other causes also, which is pregnancy, mets from CA colon, it could be germ cell tumor, it could be lymphoma, it could be chronic infections why the alpha-fetoprotein is raised. And if we see a raised alpha-fetoprotein with liver masses which are enlarging in size, well, in block capitals, bold capitals, watch out, start intervening. Biopsy. Do we need a biopsy? Well, often it is a non-invasive diagnosis. We can correlate with the levels of alpha-fetoprotein correlated with the radiology findings, which could be ultrasound, CT, or an MRI, or a PET CT maybe, correlated with the risk factors. A patient has been a long-term HBV positive patient, hepatitis B positive patient, so all these factors put together may actually lead to a diagnosis of hepatocellular CA without a biopsy. A biopsy is indicated if the radiology findings are suspicious. They're not indicated, right? So in that case, we do a biopsy. Patients who don't have a history either of cirrhosis or of hepatitis, in that case, in those people, if we see a liver nodule suspicious in size, about 2 centimeters across or more, we need to be more vigilant. We need to be more on our guard and see what's happening over there, maybe with a biopsy. Non-malignant nodules, cardiac cirrhosis, Budd-Chiari syndrome. If we have an elevated CA19.9, if we have a C or CEA, this may be to rule out a cholangio-CA in the liver, right? It could be metastatic, it could be a primary intrahepatic cholangio-CA as well. We would always prefer a true cut biopsy to an FNAC because these days, because of the molecular studies and other things, we need a substantial sample rather than just an FNAC diagnosis of hepatocellular carcinoma. Initial workup, well, depends. If the patient has the etiology of hepatitis, then it will call for a hepatitis workup, complete hepatitis B, C profile, the viral load, etc. Cirrhosis है तो उसका ये देखना होगा कि cirrhosis का workup चाहिए पूरा. We do a liver function test for if the patient comes with the portal hypertension and other things, then we would do upper GI endoscopy, ascites, splenomegaly, है क्या, caput medusae is it there or it is not, and then we do the metastatic site evaluation. It could be a chest CT, it could be a bone scan, it could be an MRI, or it could be a PET scan. So depends on what are you suspecting and where is it coming from. That will lead to your initial workup for the hepatocellular CA. Assessment of liver function. Well, how bad or good is this person with his liver? Several scores are used, and the most frequently used score is the Child-Pugh score. The Child-Pugh score utilizes 5 parameters, each one of them scored from 1 to 3, encephalopathy, ascites, albumin, prothrombin time, and bilirubin. Each one of them is scored from 1 to 3, and they are assigned class A, B, and C. A is up to 6 points, class B is from 7 to 9, C is 10 to 15 points. And the risk is class A would be a good operative risk, class B would be a moderate operative risk, and class C would be a poor operative risk. Not only operative risk, we can also decide certain drugs and treatments according to the Child-Pugh score of the patient. Staging, again, several systems are used. TNM is by HCC staging, which is what most of the cancers use. It could be Barcelona Clinic liver cancer staging. It could be the Hong Kong liver cancer staging system, the GRITEC and the WPI. We are most familiar with TNM and BCLC staging systems of liver cancer. Now, HCG is staged as, clinically, how do you stage it? I mean, for your practical purposes. It is staged either as a potentially resectable or a transplantable disease. In this, the general condition of the patient is usually good. It could be an unresectable disease, irrespective of the general condition of the patient. It could be just a liver confined disease. It may still be operable because of the poor GC of the patient, which is, I think, I just said in the upper point also about the same thing. Or it could be a metastatic disease. So liver cancer, HCC, can be staged as either resectable, unresectable, confined to the liver, resectable or unresectable, or it could be a metastatic disease. So the principles of surgery. Well, now we start the treatment part of the discussion. Principles of surgery. Well, patients should, like for every other surgery, they should be fit for surgery. And surgery here would be partial hepatectomy. You can't do a total hepatectomy unless you're doing a transplant. So usme to modality alag ho jati hai. So we do a partial hepatectomy in these patients, but the patient should be medically fit. Surgery is a potentially curative option for patients who have a adequate liver function, which would generally be the Child-Pugh A, where in the scoring system we said that the score was 5 to 6 points, and without portal hypertension. So the disease is not too advanced. The liver is still in a good shape, and it is not ramified into having portal hypertension and other such issues. Now, surgery can also be employed for a solitary mass without major vascular invasion if the FLR, the future liver remnant after surgery, is at least 20% without cirrhosis or 30 to 40% with Child-Pugh A cirrhosis and adequate vascular and biliary inflow and outflow. So all these people, they can be operated, giving the chance of cure to a patient for hepatocellular carcinoma. Now, hepatic resection is controversial, but it may still be considered if it is limited and resectable, but it is multifocal disease. The tumor is not one single tumor. You've got 3 or 4 separate nodules in the liver. So it is limited. It may still be resectable, but then it is multifocal. Or if the tumor is showing major vascular invasion of the hepatic artery, hepatic vein, maybe the portal vein, and all the other vascular structures which are there in the liver. If it shows an invasion, then you might then the surgery becomes kind of controversial. It might be possible to operate, it might not be possible to operate. Now, for patients with chronic liver disease being considered for major resection, preoperative portal vein embolization must be considered. This thing helps to increase the blood flow in the remaining part of the liver, causing it to hypertrophy, and as a result, it will leave you a larger FLR rather than a smaller FLR if you were to operate immediately. So that is the rationale of why we do a preoperative portal vein embolization. Surgery can still be done in select patients who started initially with an unresectable disease, but now they have a response to therapy, and the response has been so good that the patient can actually be operated, or he can at least be considered for surgery. I'm sorry for this. Okay, so now with partial hepatectomy, the operative mortality now in the best of centers is less than or equal to 5%. And the 5-year survival is great. It is between 50 to 70% for a patient who undergoes partial hepatectomy in a good center, in a large volume center. Now, what about transplantation? Cadaveric transplantation. Patient should meet the UNOS criteria, which is the United Network for Organ Sharing criteria. Here, the alpha-fetoprotein level should be less than 1,000 nanogram per ml. Preferably, the patient should have a single lesion, which is more than 2 centimeters and less than 5 centimeters in size. Or the patient might have 2 to 3 lesions, each one of them greater than 1, but less than 3 centimeters in size. UNOS uses MELD criteria, model for end-stage liver disease, to assess the severity of the liver disease. Now, MELD, I would run through it. The MELD score uses INR, total bilirubin, and serum creatinine. They are logged together in an equation to calculate the probability of 3-month survival, ranging from 90% to 70%. And the scores range from lower to higher. The lower is the score, the greater is the chance of 3-month survival. Higher is the score, lower is the chance of 3-month survival. Higher is your score, you get a priority for liver transplant. Lower is the score, you'll have to wait for the liver transplant. So that is how MELD and UNOS are combined. Now, let us consider locoregional therapy. This is for patients who are not fit for surgery, but at the same time, locoregional therapy can also be used as a bridge therapy. This patient is not operable as of now. I can treat him locoregionally, see the response, maybe consider for surgery at a later date, at a later point of time. So, which is what bridge therapy means. Or it could be he is awaiting transplant, he or she is awaiting transplant, and in the meanwhile, to get an upper hand of the disease or to keep the disease under control, we use locoregional treatment on the patients so that in the absence of any treatment, the disease does not actually progress. So what we can do for these locoregional therapies is we can use ablative therapies, ablation of the tumor. This can be effected by radiofrequency, it can be effected by cryoablation, it could be percutaneous alcohol injection. The other modality is microwave, and what they used earlier was a PEI, which is percutaneous ethanol injection. Now, for RFA and PEI, RFA, as I said, was radiofrequency ablation, and PEI is percutaneous ethanol injection. They both have low complication rates. However, RFA is superior to PEI in terms of complete responses, and you are looking into 66% versus 36%. So there's a huge difference between the RFA and the PEI mode of ablation of HCC. The local tumor progression rates are lower for RFA, and so Keeping these two things in mind and these two things being so obvious, the RFA has largely replaced percutaneous ethanol injections for hepatocellular carcinomas. Now, ablations may be curative for tumors which are less than or equal to 3 centimeters in size, and if the patients are well selected with properly located tumors, in the sense that the tumors are located at the periphery and they are not near any major vascular structures, so that these lesions can be RFA very effectively. Lesions which are about 3 to 5 centimeters, greater than 3, less than 5 centimeters, we can use ADT on them, which is arterially directed therapy plus minus ablation. Now, the tumor location has to be accessible for ablation. Like as I said, the tumor location, it is preferred that it is situated at the periphery away from the major vascular structures. So ablation lesions for more than 5 centimeters, they would usually be unresectable, they would usually be inoperable. So for them, what is indicated is arterially directed therapy, or maybe systemic therapy, or maybe external beam radiotherapy. So with ablation, sorafenib and other systemic therapy may not be used as an adjunct with ablation because the tumor was small to start with, like as I said in the beginning, in one of the earlier slides. For ablation, the ideal tumor away from the vascular structures at the periphery, less than 3 centimeters in size. So with these people, you don't need to supplement it with any kind of an adjacent adjunct treatment also after ablation. Now, coming to arterially directed therapies, all tumors can be treated with ADT if the arterial blood supply is isolated. Of course, I mean, if you are want to inject something into the artery to reach the tumor, then you might as well locate the artery first. So, which is what this thing says, that all tumors can be treated with ADT if the arterial blood supply is well isolated. In selected patients, it is safe with limited invasion of the portal vein also. So you can kind of stretch the patient's here a little bit. It is a relative contraindication in patients with the bilirubin of more than 3. And radioembolization is appropriate in segmental or lobar vein, portal vein, than the main portal vein thrombosis. So bigger the vein, bigger the disease, and the radioembolization then starts having its limitations. So trans-arterial, was this a slide? Yeah. So what is trans? Just give me a second. I think I have. Yeah. Okay. So what are the arterially directed therapies? Arterially directed therapies may be trans-arterial embolization. It could be trans-arterial chemoembolization. Now, in trans-arterial embolization, we would use an inert material to block the artery, embolize the tumor, and ensure that tumor necrosis occurs. In trans-arterial chemoembolization, we would introduce chemotherapy drugs impregnated on spears so that the artery is blocked, the tumor is embolized, and at the same time, it releases chemotherapy also. Or it could be DEBTase, which is drug-eluting beads with trans-arterial chemoembolization. So we use both. We inject chemotherapy, which was usually, sorry, I seem to, no, that's someplace else. So we do DEBTase, which is drug-eluting beads, or it could be along with trans-arterial chemoembolization. The other way to do it could be TARE, which is trans-arterial radioembolization using yttrium-90 microspheres. And ADT can also be used as a bridge or to downstage the therapy for further surgery at a subsequent date. Now, how do we assess the efficacy of ADT being done? It is by the response of alpha fetoprotein. We keep checking the levels of alpha fetoprotein and tumor necrosis. They are a good indicator of response to therapy. Now, the slide which I missed earlier was this one. So with transarterial embolization, the material used, I mean, we've already talked a great deal about it. So the principle was to reduce the blood supply of the tumor, induce ischemia, and induce tumor necrosis. But I want to show you this, that the material used is either gelatin sponge particles, polyvinyl alcohol particles, and polyacrylamide spheres. So all these are various kind of spheres and sponges and alcohol particles, which can be used either independently or in pregnant with drugs, and they can be used to cause transarterial embolization of the hepatocellular carcinoma. Now, what are the adverse effects of HCC ablation? Could lead to fever, it could lead to abdominal pain, it could lead to transient ileus. If we have not identified the artery properly, it could lead to non-target embolizations. There may be hidden collaterals which we may not have seen earlier, and then it might go on to do some non-target embolization also. Liver failure, of course, a rare complication, but it may be there. Pancreatitis, cholecystitis, portal vein thrombosis, bone marrow suppression because of the chemotherapy drugs which is inserted, can all be caused by the ablation with the transarterial arterially directed therapies, embolization with various things of the hepatocellular CA, and the mortality rate of the ablative procedures of hepatocellular CA. Though they sound simple, but it is quite high. It is about 5% of the total number of people may actually succumb to ablative therapies of hepatocellular carcinoma. Now, with these therapies, like in the previous one after ablation, which was for smaller tumors, smaller and well-placed tumors, sorafenib was not indicated, but now it is indicated because if there is an evidence of residual disease, which might well be because of the size of the tumor, and it is not amenable to more local treatment. So in these people, sorafenib is indicated as an adjunct to treatment. Now, external beam radiotherapy. External beam radiotherapy by a linear accelerator, it is indicated in an unresectable disease, or it could be medical inoperable disease. And all tumors are eligible for external beam radiotherapy, irrespective of the location. The beam shaping devices these days are so good. I mean, you can treat them with intensity modulated, you can treat them with rapid arc, you can treat them with, I'm sure that the radiotherapist will have other modalities also, obviously, and they can all be treated. All tumors can be treated irrespective of the location with an external beam radiotherapy. What are the modalities? Well, 3D CRT, which is 3D conformal radiotherapy, if it is a large tumor, IMRT, intensity modulated radiotherapy, or it could be stereotactic body radiotherapy. All these techniques, any one of them can be employed to treat hepatocellular carcinomas, and all of them are used with image guidance. So it is IGRT plus IMRT, IGRT plus 3D CRT, or it could be IGRT plus SBRT. So that is how you can treat all these patients with external beam radiotherapy. Well, proton beam may be used in certain situations. I won't be able to exactly say, I mean, in which locations it can be used, but it is being used in liver cancers also, and EBRT can also be given only for palliating symptoms. If there is bleeding, if there is bone pain, if there is any other thing which can be helped with radiation, then comes the external beam radiotherapy will help in palliating the symptoms for these patients. Now, systemic therapy, of course, these would be the last few slides, I think 3 or 4 remaining. Now, drugs can be used in all the patients of Child-Pugh A and in a majority of Child-Pugh B. So, Child-Pugh A with a score of 5 or 6, employing encephalopathy, ascites, albumin, bilirubin, and PTINR. So, with a score of Child-Pugh A, with a class of Child-Pugh A, you can use all drugs in these patients because they have good liver function, and in a majority of Child-Pugh B. But what do you do in Child-Pugh C? Well, it is a very open question because most of the drugs have not been tried in Child-Pugh C score patients, and it is left to the discretion of the treating specialist whether he wants to use a drug or he does not want to use the drug. Now, what are the drugs used? Well, we started with sorafenib, then came other drugs, and now we can use sorafenib, lenvatinib, regorafenib, cabozantinib, VEGF inhibitors like bevacizumab, ramucirumab. And then, and lately, a large number of immunotherapy drugs have been used, incorporated in first-line treatment also of hepatocellular carcinoma, PD-1 and PD-L1 inhibitor, atezolizumab, nivolumab, pembrolizumab, CTLA-4 inhibitors like ipilimumab. First-line systemic therapy, well, the recommendation by NCCN is to use a combination of atezolizumab plus bevacizumab. This may be, however, it may not be possible for everybody to use these two in combination because of the cost and other factors. So, still recommend sorafenib, lenvatinib, durvalumab is again a very expensive drug, although it's quite available in India, and so is pembrolizumab. These are all immunotherapy agents. Then comes second line therapy, and this is also my last slide. Second line therapy on the disease progression can be regorafenib, cabozantinib, ramucirumab, which is a VEGF inhibitor, as I said, lenvatinib, and sorafenib. And with all these things, when we were using the chemotherapy agents, the most often used drug was doxorubicin, available by the name of adriamycin, and it gave us response rates of 10%. So overdose, of course, when sorafenib gives you a response rate of over 35%, lenvatinib slightly more than this. Regorafenib is, of course, as a second-line agent. Regorafenib again gives you response rates of in the region of 18 to 20%. So there has been a lot of progress on the treatment of hepatocellular CA, although we still have to go a long way, and that is what it is. And I think this is where I would end. Thank you very much. If there are any questions, I would be very happy to take them. Thank you.
Hello.
Hello.
Yeah, sir. There are some questions are there. I will be posting one by one question in the chat.
Yes, please do.
So I posted the first question.
What is the role of nodules in hepatocellular CA? Well, a nodule in the liver will make you suspect that there is something wrong in the liver, right? Normal liver does not have any nodules in it. So if you see a nodule in the liver, then you will have to explore it, like as I said in the screening part. So nodules will have to be screened as to whether they are, what kind of a nodule it is. I mean, is it because of cirrhosis? Is it because of a hepatocellular carcinoma? Or is it due to some any other etiology? So that is the role of nodule. It should raise your level of suspicion. So that will be the role of the nodule. if you are examining a liver or if you're seeing an ultrasound of a liver. What is the role of cirrhosis in the etiology of hepatocellular? Well, cirrhosis, as we all know, is a predisposing factor, is a risk factor for having hepatocellular CA. So that is the role of cirrhosis in the etiology of hepatocellular CA. What is the role of serum alpha fetoprotein in the screening and diagnosis of hepatocellular CA? See, in the first place, alpha fetoprotein may not be diagnostic of hepatocellular CA because, as I enumerated, it is raised in several other conditions. However, having said that, if the levels of alpha fetoprotein exceed 400 nanograms per milliliter, then it becomes highly suspicious of hepatocellular CA. Combine it with the history of the patient and the radiological findings, and you may land yourself a diagnosis without a biopsy. In the screening procedures, well, if you strongly suspect that the patient may have hepatocellular CA, if you suspect about after taking the history and the risk factors of the patients, and you do alpha fetoprotein levels on the patient, and if you see it elevated, then I would suggest that you do serial levels on this patient, do an ultrasound, do the imaging, and if the levels show a steady rise, which I said would be about more than 7 per month, then you need to raise up your level of suspicion even higher and maybe get a biopsy done. But treatments which are no longer tumors which are no longer responsive to cirrhosis to sorafenib, you can look into regorafenib, you can look into cabozantinib, and you can look into other lenvatinib for that matter is coming in a big way. And so all these drugs are available for second line now.
Hello.
Yes, please carry on.
Yeah, sir. We are done with all the questions.
Okay.
Yeah. And thank you very much, sir, for your valuable time and sharing
Thank you.
important insights on the topic, sir.
Thank you very much.